palliative comes from the word palliare, or the Latin for to cloak, as in to put a cloak over someone going through a storm.
I love that.
It's beautiful. It's a gorgeous word, but it's become so ingrained that palliative is only end of life care, that there isn't anything else we can do with that. And that scares people. It scares patients. It scares clinicians, physicians who are not ready to shift into that mindset, or are not ready to embed it in their ICU care.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Cyrus Nick, and I'm here with my co-host, Dr. Nick Mark. Nick, how's it going? I understand you recently made a trip to Korea with your family. How was that?
Yes, it was an amazing family vacation. The flights were more successful than last time. No in-flight emergency. No kid puked on me. Korea was amazing. I got to go back. There's just so much to see. Amazing food. Yeah, it was great. Highly recommend.
Yeah, I got a couple of friends there and some of my former residents now that are working there, and I would love to make a trip back there, or I should say, love to make a trip out there if ever possible. So
we went to a baseball game there, which was kind of the high point. They have a word for chicken and beer combined together into one thing, which is brilliant. Not like beer battered. Like they have chicken on top of a beer, like it's one unit.
God,
they're also just so enthusiastic about their teams. Like they're just like cheering the whole time. Like US sports teams are like low energy by comparison.
Yeah, man. Oh, I'm still stuck on the chicken and beer combination. It's like so, God, it's so next level. I love it. So we're not talking about chicken and beer today. We're actually talking about something a little bit different, although I suppose chicken and beer could play a role. I don't know. So as you guys know, those of you that have been following along with us, this season on Critical Care Time, we've really tried to focus more on some topics that are less commonly covered by critical care media. For those of you keeping up, like I said, you probably listened to episodes 4 and 21 from last season. And those are the ones where we've talked about delirium with Wes Ely. We talked about feeding in the ICU with Paul Wishmeyer. And then perhaps you listened to some of the recent episodes we've done on topics like telecritical care or Dr. Neville's 3 Wishes initiative from this season.
Right. One of our big goals in making this show was to embrace the traditionally quote unquote less sexy topics in critical care. You know, we love blood and guts as much as the other podcast people, but we wanted to cover more than that. Sure, we could do like 20 episodes on surgical airways and ketamine and other quote unquote sexy topics, but there's a lot more to critical care medicine than that. We also need to think about extubation, de-resuscitation. How do you nourish a patient? How do you ensure their sensorium is clear? How do you treat them with dignity? And sometimes, how do you allow them to die with dignity?
It's well said, Nick. On that final note, today we are honored to have Dr. Anand Iyer with us to talk about palliative care in critical illness. So Dr. Iyer is a pulmonary and critical care physician at UAB, or the University of Alabama at Birmingham, where he is an associate professor in the Division of Pulmonary Allergy and Critical Care Medicine and has dual appointments in the Division of Gerontology, Geriatrics, and Palliative Care and the School of Nursing. He was recently named Associate Chief Medical Officer for UAB Medicine, where he helps to lead one of the country's largest public hospitals and is passionate about research on and implementation of proactive integration of geriatrics and palliative care for people with serious respiratory illnesses. As UAB's first recipient of the Beeson Award from the National Institute on Aging, his research focuses on developing innovative solutions that help patients and their families living with serious respiratory illnesses age well and maintain their functional independence. He built the social media community at Palliative and leads geriatrics and palliative care initiatives through the American Thoracic Society.
Super excited to talk with our guest about the all-important topic of palliative care in the ICU. So, Anand, welcome to Critical Care Time. We're so excited to talk to you about palliative care in critically ill. Why don't you introduce yourself and tell us your superhero origin story? What got you into this?
Thanks, Nick. Thanks, Cyrus. Well, if we're talking superhero origin stories, I'm a big Batman and Superman fan. And so my superhero would be Palliative. That's Pallipulm, Palliative. And if we're thinking origins, Clark Kent era would be when I was a fellow and resident. And I think, as many of these things happen, a lot of stuff that got me started in this area happened at the bedside. And you and I, or all of us, have dealt with complex cases with families, with difficult conversations. And one in particular, as a fellow, stood out so much and really resonated that I had to write about it in JAMA Internal Medicine. I called it was Do Right by Mama. that was the phrase that the family that of the patient used repeatedly during our conversation. And we're talking about a lady in her 80s with metastatic cancer presenting to the ER short of breath, multi-system organ dysfunction, acute hypoxic respiratory failure, maybe evaporated. And this is somebody I think all of us have seen and cared for. And what was amazing was we could have done a whole host of things that medicine can provide, CVL, art line intubation, pressors, you name it. But it wasn't what she valued. What were her wishes? None of that were in line or concordant with her, according to the family. And I set aside that time, took the time to speak with him as a fellow, and really got energized by that conversation when they said, dude, please help us do right by mama. And we went a palliative focused route that was really intense on symptom management and assessment and caring for her wishes. And she died peacefully, and everybody seemed to be at peace and really, really appreciated that time. And that led to a massive switch from a research focus on things like pulmonary artery enlargement when I was measuring PA diameters on a CT scan to I'm going to look at palliative care and its implementation everywhere. And why is this happening? Why is this not happening? So much so that I went the research route, got some grants, got a BSIN, went on around the country tours of trying to promote this at ATS, and saw how many role models and giants in the field existed. Randy Curtis, Wes Ely, people at Pitt, Doug White, Joanna Hart, and Kate Courtwright, Chris Cox at Duke, and the list goes on and on. And I was like,
That's like your Justice League, by the way.
that's my Justice League, 100%. They were out there doing this amazing work. Pally Poem just helped to solidify the community. Residents started putting it in their bios, Twitter bios about how I want to do palliative care after the ICU. How can I do this? And then we're writing about it for American Thoracic Society and Chest. And now I'm in a position of leadership where I can be like, okay, UAB, what's our policies on this? Have you gotten this in the MI? Is this the same in the SI? And it's amazing feeling. But it was on the shoulders of giants.
And I think it's great for our listeners to hear too that one patient encounter, one family touch can kind of change your career course like that. Inspire you to write something really powerful and then and go in a different direction. That's great.
Absolutely true. I think it was something that gnawed on me, and we saw it over and over. A person with COPD, end stage on oxygen, several liters coming to the ICU, ILD, IPF, cirrhosis, heart failure, keeps on coming. And we're like,
Yep.
what is going on here? Has no one talked to these people? Has no one elicited their values, who they are as a people, humanized the ICU again? That's a piece of the pie, but man, I was thinking about the story as I was hiking or running, and I just could not I could not relieve that stress until I wrote it down. And fortunately, Jam Internal Medicine picked it up, and we're excited to run with it.
That's awesome, and I think part of this episode is really going to be to try to shed some light on that recipe, the recipe for that pie that you've kind of described, and how like there are elements of it, some of which we maybe appreciate or know better than others. But the reality is, it's a whole comprehensive approach to patient care that I think we kind of owe it to our patients to master. And I'm hoping that during the course of our time with you here, we can start to scratch that surface a little bit. I know that a little bit later we're going to talk about some pitfalls and some pearls as it relates to palliative care in the critically ill. Maybe even talk about a theoretical case and how you would approach that. As we often say here on Critical Care Time, you've got to crawl before you walk and walk before you run. And so, in the spirit of crawling, Anand, can you define palliative care for us and maybe discuss some of the just common misconceptions regarding palliative care in the critically ill?
Absolutely, man. So there have been many ways to define it. I think starting with the succinct definition, it's comprehensive care for people with serious illness that's appropriate at any stage of advanced illness. That includes symptom assessment and management, advanced care planning and developing prognostic awareness, emotional symptoms, caregiver burden, bereavement, and so forth. One person described it as all hospice is palliative care, but not all palliative care is hospice. And so, though palliative care is built out of the hospice movement, it is not the H word. The misconceptions abound because of the nature of what we deal with it in our current society. So, as ICU clinicians, we're often engaging with palliative care only at the very end, very, very end of life when we're talking about a terminal extubation or a difficult goals of care conversation that isn't going the right way. So we engage the specialists. And that's secondary or specialist palliative care. But there's so much more that we as ICU clinicians can do, and that's primary palliative care. The misconceptions include it's only end of life care, it's only hospice. They're going to narc out my patient, put them on a lot of benzos. It only means goals of care. I'm the DNR guy. It's withdrawal of care. They're not ready for palliative. People don't want to go palliative. Geez, like this is what I get a lot of. And myth busting is my favorite thing to do. And that's why I love to just kind of like tackle any of those things, whether it's going palliative or probably the worst phrase I hear, which is withdrawal of care. It's not that.
If people want to see me like really just scowl on rounds, like say
Yeah.
that. Yeah, I hate that one. We
Yeah,
never
say
stop
that,
there.
say that, and we're like, well, actually, it's a transition to a different type and a different quality and quantity of care that could be just as intense,
Or
and
more
for others,
intense.
more intense. Yep.
Well, thank you for giving us that overview, and thanks for laying out some of those myths to bust. I want to get a little bit more granular and ask the question: what are the goals of palliative care, especially in our population in ICU patients, and how does the palliative care that we provide in the ICU differ from palliative care delivered, for example, in hospice?
Yeah, man, that's a good question. And the best sort of way to start this conversation is what does palliative mean? And as I've, been, I'm a the human supporter of the word palliative. You'll see this discussion pretty widespread of what people call it. Some people call it supportive care, and that's what we do in the ICU a lot. But palliative comes from the word palliare, or the Latin for to cloak, as in to put a cloak over someone going through a storm.
I love that.
It's beautiful. It's a gorgeous word, but it's become so ingrained that palliative is only end of life care that there isn't anything else we can do with that. And that scares people. It scares patients, it scares clinicians, physicians who are not ready to shift into that mindset or are not ready to embed it in their ICU care. We often, as ICU physicians, pigeonhole palliative care to the goals of care talk or the goals of GOCs, the goals of care conversations, or even the palliative extubations, which are terminal extubations. So that's where it's limited, but it's got a breadth. That's where we've historically limited, but there's so much more, including symptom assessment and management, more broader communications across interprofessional teams and coordination. That terminal extubations is a big thing, but then there's caregiver engagement and bereavement. So you could do a lot of work in that space to define that more clearly.
Anna, now that I think we've done a great job of laying the foundation, I want to get into the meat and potatoes here. And maybe we can start with some common pitfalls relating to palliative care and the critically ill. And I like to do that because that way the pearls maybe will be fresher in their minds, in the minds of our listeners as we, as we kind of proceed down this road. Nick, do you have one you might want to start us off
Yeah, I
with?
mean, I think one that I've seen several times is sort of like, treating palliative care like the closer, like, um, oh, this is really going bad. We better get palliative care involved, and sort of introducing only sort of at the end of life, the late integration of palliative care. And this creates a bunch of problems, but I'd love to hear your reaction to that.
Yeah, that late concept is still being defined. What is actually late? Is it an hour mark? Is it 72 hours? Is it 48 hours? When is too late? I prioritize palliative care through my rounding checklist and put which is oftentimes what's their code status is the last thing on a checklist that you round in the ICU and they say full code, DNR, that kind of thing. Well, I'll put that up top and it's not that, it's what's their values. Have we talked with the family? Have we done all these things? The reason being is initiating that conversation plants the seed, helps you to discern where you might have difficulties. There might be not clearly identified surrogates. There might be people that have come in from across the country, and you're not really engaged in that understanding of the family dynamics well enough until middle of the road, and then now you're trying to start this. So there is a benefit to integration of the principles of palliative care, whether or not you're going to consult the specialist yet, but starting with understanding those surrogates, understanding the values of the patient and who they are, and then really making sure you've laid the foundation for symptom assessments and management, decrease the tension a little bit, set some time limited trials, and you start all that stuff on day one. Whether or not you're going to say, I'm going to change the code status here, that should not be the goal. But it's like I'm setting the seed because that is so beneficial without seeming like you're just hounding the topic of what's the code status, what's the code status. That we don't need to do that. Just flip the frame and you'll feel so much better. And the reason I say this is because whenever I've started that process with residents and fellows, the tension is just reduced. There's so much less tension. It's like we're balancing the ICU forces. If I think about what Matt Schuba's done with intensivist movement, right? That's a model of trying to be so zen, but really cool, really elegant, and how they use that to actually do better care. And that's the same concept. I'm actually going to use Palliative to make the care overall just really smooth, really seamless, really integrated, goal concordant. People feel good, residents feel great. They're still doing high quality critical care, but their families are like, this sounds really good. We've got this trial. So the tension is reduced. We've understand the goals. We've understood their symptoms. We've set some time limited stuff. We've all done that because we did this earlier and not waited till 2 or 3 days in.
I really like the framing, by the way, of talking about goals as opposed to specific interventions. It's always struck me as weird that like we give patients paperwork to fill out about like what specific technical things they want instead of just like tell us about what you value. And I think it leads to a lot of confusion. I think it leads to just sort of like, have you ever seen like a post form filled out where somebody says like they want intubation and CPR and dialysis, but they don't want nutrition. Like they didn't check that box. And it's like just sort of weird things that happen because we focus too much on the what and not enough on the why. Like what's important to you?
No, that's exactly right. I think that's like a vital talk mentality, that I've been trained in and others have is just who are they as a person? Humanize the ICU. Understand this person loves to ride horses. They did this in life. They're very functional. They want this. This disability actually is important to them in this way. You if you flip it that way, it's just so much better. And every time I've done that, I've understood the person better and it's come across better to families that I am doing that. And it could be the answer I don't want to hear. We want everything done. We want it all. I mean, sure, great.
Yeah.
I hear you. Like,
Yeah.
we'll help you with that, and maybe we'll set some time limited trials on the other.
I like how you describe that, and this idea of really focusing on the patient's their morals, their priorities up front, because that's really going to set the stage for who that patient is as a person. I think so often we lose the person in the patient, and their goals and their wishes are sort of relegated to that little board in the room that says like, what are my goals? And there's
Yep.
like a couple words there, and it's like pot
Oh,
marked with
OB chair. Yeah.
yeah.
That's not who somebody is. That's just like,
Or like, yeah, it's just like it's up there and it's forgotten about. It's kind of in the dusky corner of the room. And I know the nurses are like trying to maintain that and making that a priority. They're doing that as part of their nursing package. But like I feel like we often do a disservice by relegating it again to that board and to the very bottom of the list. And like, we just need their code status. That's really what we're going after because that's going to dictate our care. Well, really, it's not. Like, our care should be dictated by who that patient is as a person in the context of their disease process, or at least that's how I've approached it.
Correct. And as I even from the origin stories, as superheroes evolve, again, I'm not calling myself a superhero, y'all did, but that's okay. The the evolution of this is that I've learned more and more about it's not my values and wishes that I'm supposed to impose on somebody because I know what's right and I know that this is a terrible existence. No, actually, a person with a certain serious illness may view their life experience with a tremendous amount of like this gives me power. This is what I like to do. I'm not although I can't walk, I'm still a human and so I'm not supposed to like denigrate that or decrease that value. Again, it's what's their values. And if you've read Every Deep Drawn Breath that Wes wrote,
yeah.
there's a picture of the humanizing the ICU and putting them through the conveyor belt of art lines and CVLs and intubations. But along the way, it just turns into this gray box, and the COVID pandemic made it even more gray, and we
Right.
really couldn't understand it. So Khan and others of the three wishes are setting out the same concept of who are people, what are they about, how do they value things, and I find myself often like asking people for sound. My residents, did you know that this person did this? Like, did you not talk to them and learn that story about their life? And oh, it's because I did that in the attending. When I admitted them, I found out this stuff about them.
Right. One of the joys of being an attending is you get to not ask people about their poop every day and you get to talk about other things.
Yeah, right.
Although they may want to talk about their
They
poop.
may want to.
Yeah, that maybe their values even.
One phenomenon I've encountered is kind of like the palliative care consult, the act of initiating that consult can be a barrier to having the talks that you need to sort of explore this patient's condition and understand them a bit better. So, what can clinicians, nurses, or other healthcare professionals do in order to kind of broach the topic with the patient and their family and help be part of the team, however they may be able to support it?
I mean, that gets to the concept of primary versus secondary palliative care, right? Secondary is the specialist doing it, but I think we've got so much problems with lack of access to specialist palliative care, especially in smaller hospitals here in Alabama. That's a big problem. And we don't score very well in this access in the inpatient setting and even in the ambulatory setting. So, what that means is it's on us as ICU clinicians and interprofessional team members. Anybody can play a role in that, whether that's the nurse, the RT, the resident, the physician, the NP. Understanding the values and wishes can be done. At UAB during the pandemic, we instituted a little card that went around and talked to us about the who they are as a person, so that the family could write all this stuff down. And that's something simple that the nurse can then give to the family, and that can be done. So those are simple ways to.
I love walking in a room and seeing that, by the way. It's
Yeah,
great to have that information.
it's amazing to do that. And that gets to the challenges. There's so much lack of access. How do we integrate this so seamlessly? It's going to be on us as in the ICU to own up and get some more skills and learn how to do serious illness conversations, symptom assessment, management, and caregiver engagement. Probably the big three.
I remember when I was an EMT, when you go to people's houses, you really get a sense of who they are. Do they have like a big fish on the wall that they caught? Do they have pictures of the grandkids? Do they have, some woodworking thing they made, right? But then the
Yeah,
hospital feels comparatively very sterile, right? I mean, there's very little of who this person is there. And I mean, it's always nice when families bring something, but it's great when we give them sort of a way to do that,
yeah,
like here you could put sort of some pictures of this person, fill in their hobbies, their interests, what they like, what they don't like. It's nice.
agreed, for sure.
So sort of getting back to this idea of delaying palliative care discussions. Sometimes, I think we often don't do this because it's a slightly harder conversation, or maybe it's just not, as you said, it's often the last item on the checklist. And it's surprisingly easy, I think, sometimes for us to replete somebody's potassium to 4, but then fail to address the likely outcome of their multi-organ failure or metastatic disease. So I mean, other than putting it at the top of the list, how can we prioritize Palipalm on rounds and, in our interactions with patients and families?
Yeah, so that's the challenge I'll have to give to y'all and the listeners. As a leader at the hospital, I have the opportunity to make some policy changes, but it doesn't have to be that big. You can do this on your very own ICU. You can ensure that take this challenge. Go back to your ICU, see what symptom assessment tools exist in your ICU that are auto-populated in the EMR, a behavioral pain scale or an Edmonton symptom assessment scale or whatever. Who's acting on it? What's being done? And the nurses are measuring it, but are you looking at it as a physician? Debatable.
Do you know what it is?
Do you know what it is? How do you know what the threshold scores are? So it's like as simple as like go back to your ICUs, check on the tools that are in the EMR, and then what are being done in the protocols for it. And then as attendings, flip the checklist, put this at the first statement on the checklist on your little card on rounds that says, okay, have we talked to the family? Have we done some time limited trials? What's the values and wishes? All of that. Don't say code status. Say what's the what are the values and wishes, and let them. Who is this person to you? Is an often question I'll ask to the residents. And man, that completely, it gets them on edge a little bit because it's a challenging statement to ask a resident, who is this person to you? Like they'll say, the typical thing, a 50-year-old female with heart failure, multi-source organ dysfunction with acute hypoxic respiratory failure. It's like, cool, that's great. But who's this person? This lady is a 50-year-old. She's super sick. She had all sorts of problems at home, and then she came in with just because she couldn't breathe very well. But I get them to start talking to me about the humanity of that person, and it becomes a really neat challenge to them, and they solidify it a little bit better. And I say, so where are we going with this? What's your overarching sense of the trajectory for the next couple of days or 3 days? And challenging them to start getting out of their comfort zone to predict what might happen and where this could go is also another layer to helping you prioritize things. So those are a few ideas. So go back to your ICU, figure out what's going on in your ICU regarding symptom assessment and management, prioritizing this stuff on rounds through the checklist. Probably the next thing would be figuring out ways to get training and disseminate training. We think we're really good at serious illness conversations, but until you've actually been trained in how to do one, I would challenge you that you've got a lot to learn. Atul Gawande gets watched. He has that sort of person in the checklist, man, but like someone's watching him and making sure he's going through the processes. Even though he's done all the thousands of hours of surgeries, he still has someone watching him. And we think we're good at goals of care conversations, but I don't think we actually are because did you get training on how to do it? Do you know what a good headline means? What nurse statements are? What all that stuff means? Not until I got advanced communication training at UAB did I have a huge appreciation for the power of that.
And this is one of the things that's really, I think, beneficial about doing family meetings with multiple providers in the room, because you get to hear other people's phrases, how other people do it. Often you sort of practice a little bit in a vacuum, right? Like you don't necessarily know how somebody else does a central line. If they do something
Mhm.
different than you. But this is one of those opportunities where you can work in parallel with colleagues and learn.
Yeah, and use it, and that's a good analogy to this serious illness conversation should be a procedure
Mhm.
that's taught the Pump Crit Fellows, that has devoted time in nuts and bolts in July. You should have a whole session just devoted to this, teaching what a headline is, teaching concepts of vital talk, putting it on your phone, that kind of stuff, and having a phrase that can be used every day. All that stuff should be routine for a Poem Crit Fellow. That's just again the small piece of the serious illness conversation part of the pie. But yeah,
This is maybe jumping ahead a little bit, but maybe we can circle back to this. Thinking about sort of like using frameworks or checklists, I think you're a fan of like spikes and nurse. Like, what are some like mnemonics or frameworks that you teach people for this?
I use Nurse a lot, and I challenge residents to start with the headline. And this comes to one of the
Mhm.
questions I think you're going to ask. What does a good headline mean? In the ICU, we often do this thing where we talk about the details and the family latch on to that details, right? So they'll ask you, what's today like? And you're like, the creatinine's here. FiO2 is this. The norepi is at this number. And then they latch onto it and they're thinking, oh, that norepi is actually reduced. So that's better. So mama's doing way better today. And the overall trajectory is we're still not anywhere out of the woods. And we've got lost in the details. We've seen we're missing the forest for the trees. And in a good headline that is, despite everything we've done, your mother is still dying. Is it? That's it. Done.
Right.
One line, stop. Quit putting words after that. Quit adding on so much more. You let it sit, you hit, and then you drop and you step off and let them feel the feels. They could cry, they could be shocked, whatever. And then you said, so tell me what you're feeling now.
Yeah, that's such a great point. Like I it's only recently that I've been comfortable with statements like that, to be honest with you. Like I
Really?
always feel like I need to deliver that news, but put some positive spin on it in some way, shape, or form. Or I used to feel that way. And then I realized I was really doing a disservice for my patients. Like if there's no positive spin, if that then you're really like kind of selling them a bill of goods when in reality, I think what you just said Anand, is exactly how you should approach it. It's probably the most humane and the most honest way to approach it.
Yeah, and it's hard to do that, and it can be other things, we're just not making progress, or it's think of that newspaper, this is coming from the Vital Talk concept of what that headline should be. It's not as I think Michael Scott did an episode in The Office where he was like, "And this, and this, and oh," and then he kept on going. If I could find that clip, the
Yeah,
headline went on and on and on and droned on. It could have filled the top half of the page with just the title.
I remember what you're talking about. I
Yeah.
know exactly what you're referring
Great
to.
reference.
All the time, like all the time, and stack on stack, and then that confuses the patient. They latch onto the phrase, "This is happening," and instead, emotions are okay, silence is okay. Letting them sit with that, and then say, "Okay, now that I've said this, can we talk about next steps?" And excellent, and then they start to say, "Okay, cool. It's been 2 days on the vent. Maybe give it a couple more days." And then we start to have the opening into the window of the time limited trial or something like that.
And I want to emphasize something you said a couple of times there, which is the power of silence in these conversations. You know, lead with a good headline and then pause. And sometimes I find myself saying, like, in my head, I'm saying like pause, 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 because like silence is uncomfortable. And sometimes you think, oh, they must think I'm an idiot. I've got nothing to say. But the reality is, you just want to give them a chance to process and open up. And it takes longer than we think. And so a good long pause really does do that.
Yeah,
You know, it
absolutely.
doesn't have to be like a staring contest, like who's going to speak first, but
Right.
like, say something and then wait. And you don't have to be the one to say the next thing.
Yeah, and you know how hard that is for us to do? I mean, we interrupt patients all the dang time, and it's just our nature for some reason to want to just talk and spit things into the silence when it's like, no, actually, just say it and then hold back a little bit. Restrain yourself. Hear what and watch their facial expressions, watch their body language, see if their shoulders come down, see if things start to change. It's super hard, and then training interns and residents how to do that is also equally. I might only give them the opportunity to, let's go practice your headline. Let's sit outside. What's your headline going to be in this family meeting? How would you say this? Okay, cool, great. We've tried that. Try it on me. Let me see how that feels, and then let's go in. And I give them the opportunity. I did this with a medicine resident who's now a palliative care fellow, and she still talks about how important that was for her as a trainee to be able to give him that opportunity. Maybe not to lead the whole family meeting, but to have that piece of the family meeting, knowing that I was there right behind her to say, cool, I've got this in case the questions start to get really intense or start to derail things. And that person had like AML with multi-organ failure. And, it was a disaster at that time. So we had to really figure that out.
One other point I want to emphasize too that you said that I think is really great is like, when you're a trainee, you want to emphasize that you know stuff. So you want to use the correct medical phrase for stuff, right? You want to say AML. But when you're giving a good headline, you almost want to strip that out. And it's like you spend like medical school and residency like learning the right phrase, and then you spend like the rest of your career like trying to simplify it. And you don't say multi-organ failure, you say organs failing, shutting down, organs dying.
Mhm.
You don't say AML, you say the widespread cancer or something like that. It's like a good headline shouldn't have a lot of jargon in it or any jargon in it, I think.
That's correct. It wouldn't make any sense if it was on the front cover of the newspaper. It just
No.
wouldn't be catchy and wouldn't land. And then you give that time after that for them to cry or scream or whatever that might be. And then that's not a bad thing. And then which I think is IC we're thinking we're throwing in a towel. No, now let's realign our care to what we need to do.
So those are all great points. And Anand, I know we're going to talk a little bit later about some tools that we can use. We're going to talk about some of those mnemonics that Nick had alluded to. Before we do that, I did want to circle back as I'm kind of thinking about some of the different challenges I've encountered in this realm. So what strategies, not maybe tools, but not specifically tools, but just strategies in general, have you used or do you advocate for when it comes to introducing the concept of palliative care without the takeaway being, oh, the doctor's giving up on me or the doctor's giving up on my loved one?
I do this as part of my, routine ICU care, as framed as understanding who a person is and humanizing the ICU. I don't think there's anything bad about that. And I think people can understand that and comprehend it. It's when you start to say, I'm going to bring in this other team, and who are they? And does that mean mom or daddy's dying? Is that we're going into life here? Like, what's going on here? So when it comes time to needing to bring in the specialist support, again, doing it earlier helps to make this more natural rather than having it later. And then it's such a tension developed as it's a boom, they come in now and we've clearly shifted for some reason. So I often say, and I'm a broad pulmonologist, so I do have an ambulatory clinic. And when I say it to a person in clinic, I'm saying I'm bringing in this team of interprofessionals. They're doctors and nurse practitioners and therapists who are going to help me make sure that your symptom needs are assessed and met. First off, that they're going to help me figure out who you are and understand our values. They're going to help me set a plan for this ICU care, and that's it. Like, we're not going to be talking about they're going to help me get a good code status. We're not doing that. Then, so if I can do that early on, I have a sense of who might be super complex and need my extra help, and then I'll bring them in sooner. The problem is that there aren't enough of them,
Yeah.
and so the numbers across the country, you could need thousands more palliative care clinicians to help fill the void, and so that creates the problem of them only coming in when things are really, really, really needed. And now that's the challenge. It's like, okay, that's why that happens a lot. And I understand that variable in the practice, and how that makes it more challenging.
That answers the question, and I think that the couple big takeaways for me are it's about integrating palliative care with your practice. It's not like a separate section. It's imbued in everything that you're doing. It's that constant reminder that there is a person first and patient second. And then the other element that I think I need to remember, and maybe others do too, is while the code status may be a radial button in the electronic medical record, that is a button that we need to check because it's a metric that we need to kind of complete for every admission. But when you are interacting with a patient and you reduce it to just a checkbox, you're really prioritizing your needs as the clinician, as a cog in the machine, way beyond what that patient actually needs as part of their overall care plan. So I think your answer is going to help me remember that. So I thank you for that.
Yeah, you're welcome. And that is the point. I think I'm learning and evolving. That I think I did that way too much as a poem fellow. Was it trying to achieve a code status when that's not the purpose of this at all, and it may be completely counter to what you think. And patients may want they want everything, and you're going to do it, but you're giving a voice. You're giving them a voice. The lady that I talked about in the Do Right by Mama case, I gave her a voice, and through her family, they were able to tell me about that. When I feel like doing tele ICU consults across the state of Alabama, few people are ever given a voice into that level of care, and it's a disaster zone. I think the care is so discordant. Things are happening without their knowledge. It's a mess. It's so messy. And in doing Palm and giving that voice to patients and being a good communicator and educator about the status of things decreases the tension and aligns everything. The nurses feel so good.
Yeah.
They feel so good. Like, I don't know if you've sensed that when you've got that vibe and that balance is so smooth. We're still doing lines. We're still doing pressers. We might even do high flow, but we're not going to do this vent. And the nurses know this, and you've been clear to the interprofessional team about all this. And man, everybody feels really good.
Yeah, it's so true. Just articulating, who this person is, what they want, what they don't want, so we're gonna do this, we're gonna do this, we're gonna keep doing this, we might do this, but we're not gonna do this. And kind of laying that out, like everyone feels so much more comfortable because like that uncertainty is gone, that like cognitive dissonance of like why are we doing these things is relieved.
And I think, the process of engaging on all that and good quality symptom management is going to decrease their delirium, is going to decrease their anxiety, might reduce their breathlessness, their vitals could get better. And who knows, maybe they turn around even there's a better chance. Like, if you're implementing what I think the ATF bundle, for example,
Mhm.
that is popularized. That's a Palliative initiative. It's got engagement, it's got family, it's got symptom monitoring, it's got to do all that stuff. You need to be high quality monitoring and management, and you can implement the ATF bundle, and that's a tool. That's in a way a palliative care tool that you've instituted in the ICU.
So piggybacking off of that, how do you kind of dovetail palliation with aggressive care? Or maybe another way to put that is, can palliation be aggressive?
I think it absolutely can, and that came back to the terminology of withdrawal of care.
Ugh.
The way that, yeah, it's icky. I hate the term, and residents are doing this all the time, and attendings are guilty of it. That insinuates to me that there's an on and off switch to the ICU, that when we withdraw care, we're not wipe our hands clean and that's it. When in fact, to do a I use that just as an example, that terminal extubation, which is historically palliative extubations, or numerous people call it whatever. It's complex and difficult. Some people have even studied a simulation on how to do this and how to train residents to do this. They have no idea. Who's supposed to monitor the levels of anxiety and breathlessness and cringe and like facial grimacing? And are we giving them the adequate doses and medications at that time? So it requires a lot of bedside care. You're there with them, and the nurse is there who's monitoring consistently. It can be quite difficult. And doing a serious illness conversation is, to me, even harder than just going in there and putting the central line. I can do that in 10 minutes or 15 minutes, whatever.
And yet, as a fellow, you need to certify on X number of bronchoscopies, Y number of central lines, et cetera, at a lot of programs. But to your point from earlier, there's no such thing when it comes to these arguably more important, clinical interventions.
And I think ACGME has it as a competency. And
Right.
residents, right, or fellows are supposed to do some sort of ability to coordinate interprofessional care, and you check that box for your residents, and then engage in conversations with families. I think that's the conversation piece. And it's supposed to be a competency, but they're never trained on that. I don't think.
I feel very fortunate. So when I was an intern, I was randomized into the Code Talk trial, which was a negative RCT, but I thought it was great to be a participant. Basically, it was like a group of us met weekly for a couple of hours with actors, and like palliative care docs, and would do like simulations. So you'd have a difficult conversation. They would be like, pause. Okay, what about this? What about that? And give you feedback. And it was great. I mean, I probably had like a dozen hours of that.
Wow.
And I feel very fortunate that I was randomized into the intervention group in what was ultimately a negative trial, but I think is a very, very valuable piece of education.
Man, that's awesome. I mean, I think we need to figure out better ways of the integration of palliative care into practice, because we cannot handle the barriers that the system provides, the wide variability across different institutions, EMR differences, access differences. So it's to me, it's on us in the primary palliative care sense to get the skills, at tools that you just described. I mean, the training. So if we can figure that part out, that's the future.
Yeah. I mean, I think it's a moving target, but like the role of simulation in acquiring these skills is huge. And I just, it's expensive because it's not something that you can do with a plastic mannequin. You need somebody to actually play the part, and you need feedback and everything else. But yeah, I wish there was a way to scale that up.
And people might hate that, but was it step 3 in our training was the one where you had
Mhm.
to go in front of people and, do the live actor OSCE type thing?
Right.
CS, yeah. It was a step 2 CS.
Step 2 CS, right? Step 2 CS. That's it. So clinical skills, you're supposed to go in front of somebody and get trained. And people didn't practice, some didn't go and didn't really try hard for those things. I scored like 99 percentile on an ability to talk to people, right, on that exam. And I think those skills, some of us have extra skill sets on how to communicate with people. But my point is that there is a way to train people on how to do that. And I think there's so much opportunity to figure out how to make residents improve.
And as an aside, can you imagine if that test was graded instead of pass fail? Like, it would encourage a different sort of approach, right?
Right, no doubt. Yeah,
Or if it still existed, doesn't it not exist
They
anymore?
got rid of it, yeah.
they got rid of it. Correct. And so that that ends up being like a lot of people not knowing how to come into to a complex dynamic with a lot of tensions and feelings, and how are you supposed to handle that this based on what we're trained to do. It's repeated exposures, I suppose, until you get beat down and you burn out. I mean, what?
Maybe this is totally going off of our prepared sort of outline, but I'm curious if you think there could be a role for like large language models or chatbots in sort of giving residents the opportunity to practice this.
Yeah, maybe. I guess from the literature or from the recent data about how ChatGPT can help to respond to email questions from patients a little bit better than maybe even physicians do. There's a possibility of, speaking to a AI as a patient. I think that could be pretty cool.
I didn't even mean as a patient speaking to an AI. I meant as a resident practicing these conversations.
With a co-pilot.
Yeah, right.
That's fine. Yeah, you could do that. That would be pretty fun, actually. And then
Yeah,
you
I
get
think
the video of it, and you might be able to, you might be onto something there. If because you can't really pay simulation actors if you don't have that funding to do that. So that what you talked about with that co-talk trial, I mean, that's probably was expensive and very hard to implement in real world settings. I have done simulations on deteriorating ICU patients, how you're supposed to do really not focus on the sepsis and the lactic and stuff, but really the communication of the team and closed loop communication is what we need to learn from this. But that took a lot of effort to build something like that. So yes, that's hard to do. But AI might be a future. No.
Very cool. Very cool. Always great to see how technology might inform the future of medical education.
Mhm.
Um, so still plenty that we want to get to. So I certainly want to make sure we respect your time and we provide that kind of high quality content that we owe our listeners. One other sort of pitfall I've encountered, and I'm curious as to how I can maybe approach that in the future, is when you do all the quote unquote right things, things that feel, I guess, right to you anyway, and you're still met by resistance to even go down that route of incorporating palliative care interventions as part of the overall care plan for the patient. Perhaps the patient or their family has had a bad experience in the past, or they have these preconceived notions of like what palliative care actually means. Have you ever encountered anything like that? And if so, how have you been able to maybe reframe it to where the family is a little bit more understanding of what you're trying to do? Or is there a time when you're just like, you know what, let's back off and reset later?
No, I think the latter. You potentially risk pushing too much, and
Mhm.
I do worry about that. I mean, I think at that point you reframe it as what can I do, not what we're not going to do. So I'm going to be really good at making sure their symptoms are assessed and managed well. I'm going to make sure that our times are that we've really tried this for 3 days or whatever that is. But we're not going to push towards the cross the bridge at another time thing. I think over my career I've sort of started to evolve a little bit more into let's not push this if they're not ready. And but I think you still plant the seed and you still have that opportunity to kind of give it your all. You're right. Not everybody gets a good apple when they get specialist palliative care involved, and sometimes it can derail things. And sometimes they might have had a bad experience where they went to hospice at home and they didn't get the care they needed, and things were a mess. So they came out of it and they um, they survived. So somebody told me I was gonna die, but I came out of it and I lived another year or 2 and I'm still here kicking. I've seen that story numerous times.
Right.
And so, like,
So what is it like? Something like 20% of people who are on hospice get quote graduate. They live greater than 6 months.
yeah, I don't know the exact statistic, but it seems right that can be the case. But
Medicine is humbling.
medicine is humbling. It is indeed. But I suppose we could try to identify who are the people that would most likely benefit from the approach. And I think we could all do this as consensus. There could be some situations where we're like, oh yeah, this makes perfect sense. They need this more, and then have like layers to it, potentially little like modules that you can insert. I'm not going to go this whole end of life care route, but I'm going to start doing symptom values. I'm going to get this caregiver engaged, make sure they have some support resources, and you're still doing stuff floating around the outside of it.
I think that's great. And I think, in the interest of, like I said, kind of making sure we cover all the content that we want to get to, I'd like to sort of move on from some of the pitfalls to maybe focusing on some of the things we should make sure that we do, and getting a little bit granular here and there. I know I sort of Nick and I sort of alluded to some of the tools that we're going to get to, but I think the big thing I took away from the past 20-30 minutes or so is like the idea of early intervention, even in the outpatient setting. Starting your discussion with that clinic patient, maybe that COPD patient that has an increasing oxygen requirement, as is on like all of the therapies in the world, versus doing it at the bedside when they're having their when they're on day 12 of an ICU admission. Can you speak to maybe that early integration a little bit more? Are there kind of references we can look at to really shore up our belief in that model? What are your thoughts on that?
Yeah, that's one of my favorite questions because that's my research is defining early. My intervention that I did in my research was EPIC, which is early palliative care in COPD. And I have changed it to empowering people to independence in COPD for various reasons. But it's the early palliative care concept comes out of the literature in advanced cancer. And you go back to Temple, Dr. Bakaitis, who happens to be my mentor, when instituted at the time of diagnosis for advanced malignancy, palliative care was able to improve survival, quality of life, mood, caregiver distress, provide better goal concordance. And that's all in the ambulatory setting. Lately, Beckelman and others have looked at this in COPD, heart failure, ILD, and JAMA recently, and an interprofessional palliative care intervention was able to improve outcomes for those populations. And so what we see is that if you can start this in the outpatient setting, you can probably set the tone for a lot of different outcomes and patient-centered and family-centered outcomes improvements. And where the challenge is in what does the data show in terms of benefit in the ICU? And so I think there are a lot of intangibles here. We're not picking the right outcomes, but early palliative care in the ICU in the first like 48 hours could improve better conversations, better documentations of goals of care, better documentation of code status, and may reduce intensity of care at the end of life, potentially reducing ICU length of care. So those outcomes are starting to work. I would love to see all of this done in the clinic.
Right. So early isn't measured in hours. Early is measured earlier in illness, like before that critical illness at the end of life.
Yes, and we have tried our best to define this early concept. First, you have to get it more than usual. So just doing it is already a hard thing. As few people with COPD get palliative care. Few people with idiopathic pulmonary fibrosis get palliative care in comparison to cancer, despite having breathlessness off the charts more than in cancer. If you've just looked at it, their shortness of breath in COPD and IPF is crazy high and could benefit from interprofessional strategies to help with that and their anxiety. But nobody thinks about starting it in that because it doesn't have this nice trajectory where you're doing okay with cancer until you don't, and then things just explode. COPD kind of ebbs and flows, ILD ebbs and flows. There's exacerbations, and I'll share that article that we published numerous times about instituting this maybe after a serious hospitalization, these sentinel events. But when they start oxygen, that could be the other thing. So I think we've created a model over numerous publications called the levers model, and I think of it like levers on an old timey radio dials. And there's so many domains you could think about, whether it's lung function, symptom burden, starting oxygen, number of hospitalizations, caregiver needs. Any one of those domains can cross the trajectory of someone potentially needing palliative care, whether by you as a pulmonary ICU clinician to specialist referral. And in the article that I'll share with you, which was a policy statement for the American Thoracic Society, we helped to identify these levers that people could use and say, oh, this person looks good otherwise, but their lung function is like 30%. They might meet the criteria. Or that person with COPD that has a FEV1 of 15% is living forever and is still doing just fine, but they still have other things that are going on that still might justify a palliative care approach, even though their trajectory is long and maybe it's nutritional needs, a cachexia or something like that.
Right. I think that's one of the key takeaways of this episode, which is like having triggers to initiate the conversation as opposed to sort of like asking, do you want to have this conversation to make it more of a like triggered event? Like people who go on oxygen, like we should have this conversation.
Well, that's important. So I'll push back slightly, and that's
Please.
Chris Cox's paper in JAMA Network Open, which we can share that article, suggested that sometimes the triggers don't actually identify the needs as well as we thought they did, and having in Kate Courtwright's paper in JAMA recently was the largest pragmatic cluster randomized trial of palliative care, default palliative care, and sometimes these things the how is a little bit still murky.
Mm,
Um, the triggered based things may not work to identify what the needs are. Just that's meaning we need more detailed symptom assessment tools that are implemented to the family and the patient that's monitoring their needs in the hospital setting. Maybe there's subtle nuances for which disease needs a different kind of trigger, but it
mm,
may not do as the EMR based solution may not necessarily work.
mm,
And at least in Dr. Cox's paper, I was like, oh man, well, that didn't work. So what are we supposed to do? So maybe you need an electronic tool that's parallel to it that's measuring outcomes and
mm.
symptoms, something like that, um, to define the needs better.
Interesting. Okay, that's a great point.
Great discussion, guys. So I think another sort of pearl I'd want to focus on would be that communication element. And again, I want to peel back some of the layers here and really get at the importance of good communication, understanding why that truly is so critical here. No pun intended on critical care time. And I also wanted to see on and if there are specific tools. I know we kind of mentioned this before, but specific tools, mnemonics, etc., that our listeners could take away when they have these difficult discussions in the future.
Yeah, absolutely. We spent some time talking about the headline. We said that's important. Right after you've done that headline, you can use but you can use tools like the nurse tool. That's a tool that helps people respond to emotion. And like I said before, emotion is okay. Silence is okay, but emotion is also okay. And it helps you humanize yourself, show that you're delivering empathy because you're trying to like name the emotion. Sounds like you're frustrated, sounds like you're upset. You're trying to understand the you. You're respecting, supporting, and exploring. And all of those steps help you set a frame for empathy and how do you understand what they're going through. And tell me more. Can you tell me more about what this means when you say that? I think that a nurse statements are really good for connecting you to the family and getting through the emotions. Spikes is the other one I think we talked about. That's setting, perception, invitation, knowledge, emotion, and summarize. So you're setting the stage, you're making a quiet room, you're uncovering what they understand in the case, you're asking them what they'd like to know, you're delivering the knowledge, you're respecting their emotions, and you're summarizing what's next. We use spikes a lot, I think, but I'm really shifting to that nurse statement because I'm really just trying to understand the emotions rather than setting too much details and knowledge. So that might be one of my favorite.
I like nurse a lot. I think we'll put this on our show notes so people can see like kind of like a in a table form kind of what this looks like and maybe an example or two, but I think it's really
Sure.
effective.
And then you can do this. I think I'm looking up. Randy Curtis's team did the Jumpstart intervention, and that was another tool that could be used. Intervention. It was in JAMA in 2023. It was a Jumpstart tool that helped promote intent goals of care conversations and the outcomes of that. Clinician priming tool, more documentation of goals of care discussions, and so that was pretty cool.
One of the nice things about having this podcast is every once in a while we can do something a little bit selfish. And so I can get maybe your insights on something that I do and see whether that sort of would be helpful. Maybe our listeners could take something away from it. So, kind of in the spirit of good communication, I had an attending who I thought was really good at this. His name is Dave Bell. He's at the VA now in San Antonio. He's involved in chest, was one of the attendings back at Brook where I trained. And he would often discuss approaches to palliative care in the context of, don't necessarily ask what would the patient want, in the sense that in most circumstances, maybe this is a semantics thing, I don't know, but in most cases, most patients want to get better and walk out of the ICU. But rather reframing it as like, if your loved one were able to stand next to us and participate in this discussion, watching everything that's kind of befallen them and looking at everything that's currently before them and again participating in the discussion, how would they react to what you're saying, or this reality, and how would their moral code, their values, play into where we go from here? Any thoughts? I've kind of adopted that approach, and I've found it reasonably successful, but again, I don't know if it's semantics or what. I don't know if anything you've learned in your training has sort of like led you to approach things similarly, or if I'm just like way out in left field here.
No, I think the way you just described it is almost identical to the way I might have I might have I've learned, and I've seen some of the best do this, and using that substituted judgment concept is pretty hard. But if they were sitting right here at this table, usually family meetings are set in the conference room, right? And there's the whiteboard or something that you've cleaned up and you put the tissues there, and you're like, if your loved one was sitting in this chair right next to us and was able to be a participant in this conversation, what was that reaction? I think I've heard that used a lot, and I feel like it lands. The Back to our point of having earlier values based serious illness conversations, then you can start to say, based on what you've told me about this person and who they are as a human and what they valued so much, I don't know if this is really meeting their standards.
Yeah,
And there is that opportunity for you to be able to say that to them and then hear that, let it land, and see how they respond to that. And they were like, "Oh man, you're right. Mama wouldn't want this at all. She they could say she's a fighter, but this isn't like she's wanted to be because you've known them, you've learned about them, and then you can take that next statement after you've just said if they were here, you have the ability to understand it and push that part into the conversation. Yeah, based on what you've told me about who they are as a human and as a person, I don't know if this current state is where she would have wanted to be in this reality."
Yeah, I think it's a really powerful framing, and it's often a powerful moment in these conversations when you get people to sort of like, not what do you want? You want your loved one to get better. What would they want?
Yeah,
Yeah.
exactly.
And I've literally, I remember one time somebody like literally did that. They had an empty chair. It was like, Elijah's chair or something. And
Oh, that's interesting.
yeah, maybe a little over the top, but like potentially powerful.
and I think I'll just say, like, maybe again it's semantics or whatever. Because of how I trained, I've like really gotten away from the what would they want idea, and rather focus it on like, how would they react to the situation? Because I feel like when I've, and maybe this is just the way that I phrased it, when I've kind of gone down the road of want, they're like, oh, well, they want to be better. They want to get better.
Yeah.
They want to get on out of here. They want to do this. They want to do that. And I find that like sometimes that ends up being a couple steps backwards. I'm having to like
I
rebuild
know
it.
I would be worried about that too if you framed it in the want concept, and I think a lot of people want to just not be in pain and not suffer
Right.
and not do all these things, but they also want to live, and so I want to live, I don't want to die, like, that's gonna be the want question is a little tricky. Um, but yeah, that's cool, and then some of the other stuff that I've learned the best is your tone, your delivery style. I saw a pediatrics attending just get on the ground level with the family, like literally squat down on rounds and is sitting below the parent of this child. I thought that delivery skill was incredible.
Yeah.
And it just sort of like took that her like looking up at him on rounds and she's sitting in the chair to now she's here. And it was subtle and it was just remarkable how that kind of a position change just really took the tension off the mother of this critically ill child, and he was able to just really diffuse the tension so well with just positioning and sitting down and having lots of chairs and setting the tone and making quiet. I mean, you can do a lot of those skills residents should bump in, right? And we're talking about goals of care on the side of the bed right next to this person in the ICU. That's not going to work. It might
Right.
not, you know, like there's a setting. That's the spikes part. Set this, make sure the setting is good.
Right. Yeah, there's sometimes you just see somebody do something and it works so well. You're like, oh my god, I have to remember that. Like, I remember another one that I saw was the power of just like making your voice a little softer and lower. Like if somebody is yelling and you respond by talking even softer, they're yelling more and you talk even softer, it has this amazing like calming effect. It's like it feels weird for them to be yelling if you're talking softer. And like it's a very subtle way of like sort of like calming things down without saying anything, just the way you say it. Very powerful.
Yeah, no, I've had that experience even a few months ago in the ICU with a family member that was just yelling at us about this or that or the trach or whatever, and just getting very mad. And each attendant kept adding to that anger, and she was just really upset about things. And then we were standing over them, and she started just doing that to me. And I said, "Hold on," and I literally stepped back, calmed down, and said, did that exact thing. Took a different approach of okay, I'm sorry, kept saying that word and kept saying, "I apologize, I'm sorry," and de-escalated that tense moment to, "Okay, now we still have to get back to this understanding what are the goals of this my week as attending gonna be for this patient." And we were able to reframe it and didn't think she was just getting given up on or throwing in the towel. But yeah, subtle art of communication strategies need to.
Jedi mind tricks. Yeah. It's actually a good segue because I think sometimes, when patients are angry, it can be very distressing for us as caregivers. And maybe we should talk for a second about like strategies that we can use to make sure that the ICU staff feels supported. Because sometimes that's sort of a related sort of aspect of palliative care, right? It's not just supporting the patient and the family, but sometimes there's a lot of distress for nurses who have cared for somebody for weeks or months in the ICU.
Yeah, I think, like I alluded to earlier, I feel like implementing Pally Palm or what Matt would do with Zentensivist mentality makes the whole ICU experience just overall better. Potentially, the outcomes could be even better because you're doing goal concordant care and that just works more smoothly. So, from a staff and team standpoint, to articulate what the values and wishes of the family are means that you need to understand the overall trajectory. You need to understand how the system is working. And so you have to understand that big picture. And for the residents, this helps them to understand trajectory and where things might go, removes a little bit of tension from them not knowing. The nurses who are right there, that's intensive care. It's not intensive physician care as much as it is intensive nursing care. They're the ones that are delivering a lot of this. And I feel like those they can see it, they feel so distraught, and they feel like they're just doing stuff that shouldn't be done. Helping them through this could reduce their burnout, and I feel their tension has come down as well. We will often debrief using the tool of debriefing as much as possible to allow for decompression after really tense situations is incredible. That being like a code, that I use debriefing after a code quite often and will take the stress. And then that includes the nurse, the RT, the residents, and what went well or what did not. So that can be applied to really complex cases here too. Our what have we done right in terms of this goals of care conversation and what didn't go well. People, you got a chance to cry if you want to because this was pretty hard for you to do as an intern or a resident. Like it's okay to let some emotion out and give them the space rather than just moving on to the next patient on rounds. So I think that in the pandemic, we didn't have that opportunity to debrief too much and to really have concordance and good quality end of life care throughout. And I think that just contributed to nursing burnout rates through the roof. So I think having family around now and having them in the rooms and letting them be a part of the care really escalates things for a lot of people.
Yeah, I think another tool that I found, and I think there's some research behind this idea of death rounds, which my old fellowship, they're doing that. They're doing that currently. But I think it was first discussed in the Journal of Critical Care in 2005, this idea of basically having formalized end of life discussions with the medical residents in the ICU, so with the house staff, and really that could extend beyond to include your nursing staff. And respiratory therapists, et cetera. But I think in that 2005 multi-center study, it was really, they were looking at having these formalized meetings where they looked at the emotions surrounding the care of dying patients, the emotions surrounding intensive care interventions, and how trying that can be as a caregiver. And from that study, it was really, the results were overwhelmingly positive, I think, from the house staff, where they basically felt that it was helpful to have these discussions with peers, with mentors. It was cathartic. I'm curious, Anand, if you are familiar with this concept, if you guys do anything like this, or Nick too, if you guys do anything like this over at Swedish or any of the other, the hospitals that you work at.
No, I think death rounds are pretty interesting. They're good philosophical moments to sort of decompress, to think about things. We did those briefly. You have to have a champion who can lead some of these, whether it's your ethics consult person or a physician who has some training in that. The palliative care team might be able to help with that. But I feel like at academic settings, those definitely work to allow residents to digest and figure out what might have could have done better, but what are the emotions that they experience in that complexity. So I support them, and that's kind of what I was saying with the debrief is
Right.
that exact thing. A unexpected death in the ICU is the same concept, or even a terminal extubation with lots of family around. I think that's still a moment for the resident to decompress of what how did that go? What did you learn after that? It's intense. So yeah, I think you could incorporate it, just finding champions, would be hard.
We've implemented this at my hospital, and this is, by the way, without residents. This is mostly, nurses, respiratory therapists, physicians. We call it Death and Donuts, sort of a monthly cadence, meeting. Do it in the morning so that night shift and day shift can both sort of
Nice.
participate. Yeah, I think it's a really nice thing. I think, I mean, it's the kind of thing where the people who choose to participate get a lot out of it, and there's some self-selection there, but I think it's, like, really valuable. We During the pandemic, we did it over Zoom, which, A, had no donuts, but B, I think just wasn't as effective as being in the same place. So it is one of those things which is better in person, I think.
Yeah. Anand, very grateful for your time thus far. I kind of wanted to close out briefly with a case study, kind of a case that I developed where we could maybe use that as a means to explore some of your takeaways for this episode, and kind of dovetail the case with really what our listeners can learn from this, just putting it in some context. So here it goes. So we've got a 22-year-old male. He's got widely metastatic melanoma. He's presenting to the ICU from the ER with a concern for septic shock from post-obstructive pneumonia related to lung mets from the aforementioned melanoma. The patient and his family have unfortunately and understandably, I think, been resistant to palliative care discussions in the past. And he's been on first, second, and third line therapies to include experimental therapies, really without any significant response. Despite all of this, he's got this metastatic disease to the CNS, lungs, the liver. And so I guess looking at a case like this where there's some maybe resistance to palliative care at this point, and there's been a bit of a history. I mean, this person didn't just wake up with widely metastatic disease. If we had a time machine, let's say, using some of the pearls of wisdom that you shared with us during the course of our hour or so chatting, how could we maybe approach this? Particularly, it's a younger patient too, and I know I always struggle with younger patients and having these discussions. So I would be curious to know any kind of parting thoughts that could inform this case and those beyond.
Yeah, this is a great case, very complex. The I do study geriatrics, and so aging is important to me. But in geriatrics and palliative care are often only for those at the end of life or older adults. But I would argue in my research, just trying to push it, that everybody could benefit from these kinds of approaches, no matter their age. It's just significantly more challenging. It's so much harder. If you had a time machine, I would have gently started these conversations in the clinic, in oncology clinic myself. If I was an oncologist, would have loved to have that thing as a primary care physician. This person has lung mets. I'm sure that they've been seen by IP, interventional pulmonary, or someone like that. There's opportunities at each point to sort of better understand that. So early palliative care in the ambulatory setting might have helped to plant these seeds a little bit better. But in this ICU setting with multi-organ failure and septic shock, he sounds like he's dying, and we need to do this.
There's the headline, by the way.
Yeah, and so I feel like I'm not certain what this resistant to palliative care discussions actually meant, and what was that painted? Who did this? How did those conversations go? But here we're in a new situation. We're in a different state here, and despite everything we've done, your son is dying. Your loved one is dying. And that's my headline. And I feel like that complexity might be it. And let's hear it. Let's hear what they say. I'm not going to push it. I'm going to use in their statement. I'm going to understand their emotions. I'm going to understand the background of things. I'm going to have already talked to them about who he was. He played football. He was good at college, this or that. I've understood their values, about his strengths and who he was as a person, and I can incorporate it into the conversation a little bit better. It might not land, but I've tried to do that through a good headline and a good conversation. And again, it's not, the younger patients are always harder. They're going to be more difficult, but there's still an opportunity to engage in this, for their sake. You might not be ready, but you might still be able to plant a seed. Then you can still say, okay, cool. Now that we've discussed this and I've heard your feelings about this, let's set the stage for things. They're on the vent. We've kind of reached our limit here. Can we set a time frame? Would that be something we could talk about? If we're not making any more improvement after 3 days, let's reapproach this conversation. And if things go worse, maybe we need to come back in and let's have this conversation again. That's your time limited trial concept, and then I'd be able to still maybe impact some change there without having any special palliative care involved in any way to this. Um, this person I might try to own even more. For me, I would probably be like, I built this relationship with this person and their family, and I'm not ready to bring in the specialist yet. I don't know if that would create the tension. So there are chances I might not, for the sake of not creating any extra tension.
Yeah, I agree. Sometimes more people can confuse the situation, and you if you have this relationship, you admitted this person, you've cared for them since the beginning of their hospital course, like, sometimes that's almost easier. You have more history.
Yeah, I mean, it's what we're trying to do is build ownership on our own, that we're doing this well. As long as you've been trained adequately to do what you're talking about, you feel like you know how to assess their symptoms and their needs better.
So Anand, thank you so much for answering that question, helping us understand, how you would approach this patient, just to really make sure that our audience has, no questions at the end of all of this. Maybe we could flesh out, before you leave us, those 5 takeaway points that you wanted to leave for our listeners.
Right. So we misconceptions abound for palliative care. So understanding that it is a comprehensive approach to care for patients with serious illnesses, and is appropriate at any point along the trajectory. That's got to be a number one take home, not just pigeonholing it to end of life care or withdrawing care or terminal extubations. There's so much more that it can provide. What can you do as a clinician that can improve your level of skill set in this domain? Well, go back to your ICUs and figure out what your symptom assessment tools exist in the ICU, and how do you react to them? Are they adequate and comprehensive enough? And what do people do with the scores and the symptom tools? And what are those policies? You can make your own. You can lead that policy in your own unit, and then MICU or whatever unit you lead back home. It's not too challenging. So I would challenge y'all to do that. Then get more training in this space. So there are serious illness conversation tools and training opportunities through Vital Talk and others. Learn and practice, and then teach residents. Go to capc.org. You can find training in primary palliative care for the ICU that exists there. Go back to your home palliative care teams and engage in conversations with them about how well they can be integrated into rounds. What are the thresholds for integration? Work on ways through your fellowships of integrating palliative care into training practices. So serious illness conversations or symptom management, terminal extubation tools, that kind of stuff. And then we didn't get to talk about it, but the family caregivers and supporting them is going to be crucial. So don't forget about them as they stand in the side of the room while you're kind of doing things. Like, they're so crucial.
Great, great. So you've given our listeners a couple of resources where they can learn more. Any other resources you want to plug for them?
No, but I'll email those articles that the policy statement really lays out early palliative care and serious respiratory illness, that helps you to frame things. If Twitter didn't become a hellscape, if Palliative existed, and it's created an international community of people that are like-minded in this space, and I have people representing it from different countries. I haven't really created a website or anything like that yet, but
Keyword is yet. Yeah. And when you do, we'll promote it.
that's awesome. Yeah, yeah, correct. And if the trajectories in the multiverse would have been different, and billionaire evil people just taking me.
I love, by the way, that you really embraced my superhero origin story. Like this whole conversation has had throwbacks to that. I love it.
Absolutely, man, for sure.
Anand, thank you so much for your time today. Hopefully, I didn't butcher your first name too many times. I really did try. My apologies for any of the slip ups. I think, we're very grateful for folks like you in the palliative care space that are both intensivists and palliative care experts that are able to kind of marry that and lead us really from the front lines and showing us how we can be better for our patients, because I think at the end of the day, that's what's really important. I hope that our listeners really enjoyed this chat and that they come away from this discussion with an appreciation for really how important palliative care is in the critically ill patient, even beyond the ICU, how important it is in the ambulatory setting. And how, while topics related to death and dying can be really hard to discuss, it doesn't mean we should shy away from them, and really we should embrace that. It's a big part of our job as caregivers. If you guys want to learn more about this topic, if you want to read more, you should check out our website where we have our show notes. That website, for those of you that don't remember, is www.criticalcaretime.com. And while you're there, you can subscribe to our mailing list and leave a comment. Guys, today I think we had a great discussion with Anand Iyer. Dr. Iyer really helped shed some light on the world of palliative care as it relates to the critically ill. We really do hope you guys enjoyed our chat. And even more importantly, that you guys can walk away from this with an appreciation for how important palliative care is in our population. And that, while topics that relate to death and dying can be really hard to discuss, that does not mean we should shy away from them. And in fact, in doing so, you may be doing a disservice to your patients. So if you do want to learn more or review any of this content, please go ahead and visit our website. That's www.criticalcaretime.com, where we're going to have our show notes, as well as opportunities to sign up for our mailing list and leave a comment, of course.
And with that, we come to the part of our show where we like to say thanks. First off, thanks to our guest. Amazing job teaching us, educating us, and our listeners. Thanks to all of the people who have left us reviews, comments, or given us a shout out on social media. We really appreciate your words. We read them. They warm our hearts. For those of you who have not yet given us feedback, we really hope you also enjoyed our show. If so, be sure to subscribe, give us a like, and please, please, please give us a 5-star review on your favorite podcast app. This really helps other people find the show. Just a reminder, we love hearing from you. You can tweet or X at us at Crit Care Time, or individually at Nick M. Mark, at Askins_Razor. You can also follow us on Threads, Instagram, and YouTube.
We'd also, of course, like to take a moment to thank our sponsor, C-Star Medical. We're fortunate and grateful that this episode and all episodes of Season 2 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
And before we go, we'd like to thank all the incredible members of our podcast team for helping make this show a reality. First off, the production team over at Podpaste, who edit out all the uhs and ums and make us sound smart. Certainly, Kurt Belknap for the theme music that you're hearing over this right now.
And of course, it's time for disclaimers. So the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening. I'm Dr. Cyrus Nick.
And I'm Dr. Nick Mark. See you next time.